Assalamu alaikum wa rahmatullahi wa barakatuh. Let's discuss a new topic in the cardinal manifestation of cardiovascular system, that is heart sounds and murmurs. So let's begin with the name of Allah. So first of all, we will learn the basics of auscultation. So for that, I will zoom this picture, as you can see here. So mainly there are four sides where we auscultate. So this is the aortic area, pulmonary area, tricuspid area, mitral area. This is called as E for Erb's point, ERB, Erb's point. That is important in some murmur. So remember that also. Okay. So aortic, these areas doesn't mean that those walls are present at that site only, but they mean that the sounds of that respective wall are best heard at that site. That's what those area mean. Okay. So A for aortic sound, it is at the right intercostal space. B for pulmonary, left intercostal space. Erb's point is the left third intercostal space. Tricuspid, left of the sternal border in the fourth intercostal space. Mitral, left of the sternal border at the mid clavicular line in the fifth intercostal space. And remember one thing here, the apex, this one, this is known as apex. The apex includes the tricuspid and the mitral wall. And because the S1 sound is because of the closure of atrioventricular walls, nothing but mitral and tricuspid wall, that's why the S1 is heard loud in tricuspid and mitral area. And this is base. So base includes the aortic and pulmonary walls, and S2 is loud at these areas. So S1 is heard as lub, S2 as dub. Lub, dub, lub, dub, lub, dub. So you can remember this by this mnemonic. All patients enjoy taking medication. A for aortic, P for pulmonary. All patients enjoy. E for Erb's point. Okay. Taking. T for tricuspid, M for mitral wall. Okay. Similar things. Okay. So second, A is second right intercostal space, ICS at the sternal border. P second left intercostal space at the sternal border. T fourth or fifth left intercostal space at the lower sternal border. M fifth left intercostal space at the mid clavicular line, that is also known as cardiac apex. And here you can see this M is also the site of the point of maximum impulse, that is known as cardiac impulse. Cardiac impulse. What is cardiac impulse? So if this is the apex of the heart, this is the apex of the heart. Okay. During contraction, this will become like this, somewhat enlarged. If this is the previous one, up to this point it was there, this will stretch up to this point, and this stretching will hit the chest wall. That is known as cardiac impulse, which is felt at the left midclavicular line in the fifth intercostal space. Okay, that has some significance. When there is left ventricular hypertrophy or right ventricular hypertrophy, it will get shifted. Or when there is what do you call when the heart is placed in the opposite direction. Okay, then the cardiac apex will be felt in the right part of the chest, not in the left part of the chest. Okay, that is known as something that is called in cardioversion. Okay, no, not cardioversion, something is called. Now that is about basics about the auscultation. How do you auscultate? So in the stethoscope you will have, this is this, like this it will be there in stethoscope. Okay, so this is the bell of the stethoscope, and this is known as the diaphragm of the stethoscope. Okay, the large disc part, and the small disc part is the bell of the stethoscope. So use both diaphragm use the diaphragm for high pitch sounds and the bell for low pitch sounds. Now prepare the patient. How you will prepare? Patient positioning. Depending upon which murmur you are suspecting, you need to prepare the patient. The murmurs at the base of the heart, that is tricuspid and mitral wall, will be best heard when the patient is supine left lateral decubitus patient. In this patient, the mitral wall murmur will be heard best, and the murmurs at the base of the heart, that is aortic, for example, like aortic murmurs, that will be heard best when the patient is sitting and leaning forward. This will increase the aortic murmurs, as well as this will increase the pericardial rub sound also in pericarditis. So patient positioning is also important. Now time events. How you will know whether this is S1 or S2? So palpate the carotid pulse. So S1 precedes the pulse and S2 follows the carotid pulse. That's how you differentiate between lub and dub. That is nothing but S1 and S2. And one more important point is right-sided events. That is nothing but right heart events, tricuspid valve and pulmonary artery. These events are intensified with inspiration due to increased venous return. Increased venous return will increase the volume of blood in the right atria and right ventricle. That's how there is change in the right-sided events with respiration. Okay, and they will increase when there is during inspiration because of venous return. That's all about the basics of auscultation. Now we will first learn about heart sounds. So I will say it initially only. So we will learn about S1, number 1. Remember all. First I will just, okay, S2 will be S2 has two components. So split S2, S3, S4, clicks, ejection clicks, and opening snaps. So these are all heart sounds. Okay, now one point you remember, basically these are all heard as triple heart sounds, irrespective of whether they are present in the during the systole or diastole. These are heard in the stethoscope as triple heart sound, nothing but 3 heart sounds. So 3 heart sound meaning it can be split as 2, S1 S2 S3 or S1 S2 S4. It can be S1 S2 with ejection click or S1 S2 with opening snap. So these are basically heard as 3 heart sounds. And third point is, remember this one, all of them, most of them, except 2 opening snap, OS, opening snap, all of the triple heart sounds are heard in diastole. Only the opening snap is present in the systole. All of them are heard in diastole. Okay, so these are the basics you remember. Okay, now moving forwards. First heart sound, nothing but S1 or lub of the heart. So what is the mechanism of that? Closure of the atrioventricular walls, that is nothing but mitral and tricuspid wall. At the onset of ventricular systole, the mitral component M1 is louder and it precedes the tricuspid wall, that is T1. So it will be like this, M1 T1. Okay, so S1 is equal to M1 T1, but this is not heard as split sound. Okay, anytime. So it is, but just remember M1 is louder and it precedes T1. Okay, so M1 T1 is equal to S1. S1 is loudest at the apex, as we have discussed before. Now, so what is the clinical correlation of the S1 sound? Important. Okay, So loud S1. So S1 is loud. So when S1 is loud? In mitral stenosis, in tachycardia, and short PR interval. These are the cardiac causes of loud S1. Mitral stenosis, why it is loud? Stenosis means the orifice, if it is this much, in stenosis it become this much. So the orifice diameter will decrease in stenosis. In regurgitation, it will the walls are I will say what is that regurgitation and stenosis. Just remember, stenosis is decrease in the diameter of the wall. But one more thing one more thing which needs to be remembered is, in mitral stenosis there is decreased orifice of the wall, but the walls are pliable. Pliable meaning they are very floppy. They are floppy. The cusps are floppy. That's why decreased orifice and pliable cusps, they produce S1. Because large amount of blood has to go through a small orifice and the walls are floppy, so that will cause loud S1. And S1 will not become loud if this mitral stenosis is accompanied by thickening of the wall cusps. Remember this point. Okay, so just remember, that's the mechanism I have discussed. So loud S1 you will hear in mitral stenosis, tachycardia, okay, because there is increased blood flow. Okay, so relatively there is increased turbulence. Okay, remember, uh, uh, okay, just remember, tachycardia you will have loud S1, and in short PR interval you will have loud S1, short PR interval. Okay, so that is the importance of loud S1. What is soft S1? Soft S1 is seen in mitral regurgitation, heart failure, long PR interval. These are, and pericardial effusion. These are cardiac causes. Obesity and emphysema. Of course, there are the chest are barrel shaped, and obesity, fat is so much in between the stethoscope and chest. So that's why S1 is soft in these patients. Pericardial effusion, there is fluid, so that's why the S1 is soft. But remember, the more important to remember is mitral regurgitation, heart failure, and long PR interval. Remember one thing. So murmurs of stenosis means difficulty in, for example, if this is the left ventricle, okay, and this is the mitral wall. So normally mitral, the blood flows from here to here, so this is normal flow. When the orifice becomes small, then that will have some sound, some murmur that will have, because orifice becomes small, then the flow of the blood becomes turbulent. Meaning, for example, if you are throwing water from a pipe, so you will not have the gush of water from that. You just press the opening of that pipe, then the gush of water which comes out will have a fast speed, and it will be turbulent. And if it touches some sound producing thing, no, it will have some sound. Similar thing happens here also. So, okay, when the orifice becomes small, turbulency will increase. So that causes murmur. So this is stenosis. In stenosis, murmurs are produced like this. Regurgitation is nothing but, normally the mitral wall should prevent the blood which is present in the left ventricle to reverse back into the left atria. Okay, but because of incompetency of the mitral wall, the blood will flow in the reverse direction. That is nothing but regurgitation. So I am giving an example of only mitral wall. This applies to all the walls. Okay, that is regurgitation. Incompetency. Regurgitation is nothing but incompetency. Flowing backward flow causes murmur. Okay, so soft S1 you will hear in mitral regurgitation and heart failure, short long PR interval. Okay, and emphysema, pericardial effusion, and obesity. More important is loud S1. Loud S1 you will hear in mitral stenosis, okay, in mitral stenosis and short PR interval and tachycardia. In tachycardia also you will hear loud S1. Variable intensity you will have in atrial fibrillation because the and complete heart block. The rhythm will be altered, so intensity will vary. Now coming to the second heart sound. What is the mechanism? Closure of the semi-lunar valves, nothing but aortic and P2, A2, P2, pulmonary valves at the end of ventricular systole causes this second heart sound, dub, okay, dub, okay. But A2 is louder because it is from the left ventricle. Left ventricle is powerful than right ventricle, and it precedes P2. So it will be like that. S2 is equal to A2 P2. Okay, and normal split of A2 and P2. That is normal physiological split of S2 you can hear when there is when you say the patient to take a deep inspiration. Not deep inspiration, I can say. No, when the venous return increases, okay, when the venous return increases, okay, so at that time, for example, in inspiration only, so at that time you can hear this normal split. Okay, I have this video, you can hear that. So physiological, physiological splitting. Inspiration increases the venous return to the right wall. So when there is increased volume of the blood, so will be delaying in the emptying of the right ventricle, delaying in the emptying of blood to the right ventricle. So that causes delay in the closure of P2, and that's why A2 P2 will become like this, A2 and P2. So there will be some gap. This gap will be there. So delaying P2 and causing a split S2, A2 then P2. This is normal. Okay, in normal inspiration, there will be split S2. Now, what is the clinical importance of that? Normal physiological splitting is there, but that split is larger than the normal physiological split. That is nothing but wide splitting of S2, wide splitting of A2 P2. So A2 and P2, no. So if it has to become, if the gap has to increase, then P2 should either move forwards or A2 should either move backwards. Then, and at that time only, you will the gap between these two will increase. So when that happens, so delayed P2 happens when there is right bundle branch block. So the conduction is delayed. So delayed contraction of right ventricle, that causes delayed P2 and wide physiological split. And pulmonary stenosis. So orifices has become the diameter of the orifices becomes small. So in order to empty the ventricle, the time taken will become there'll be delay. Okay, that's why the delayed P2. So delayed P2 in RBBB and pulmonary stenosis. Early closure of A2 happens when there is severe mitral regurgitation. So what happens? So if this is aorta, this is the right ventricle, and this is left atrium, and this is the left ventricle, and this is the aorta. So the blood which is coming, and during systole, it is going back because of severe mitral regurgitation. So small amount of blood will remain here. So aortic valve will close early. So severe mitral regurgitation causes early closure of A2, and that causes wide splitting of S2. So that's one thing. Right bundle branch block, pulmonary stenosis, and severe mitral regurgitation. Fixed splitting. So the change which you are seeing, you will not see in inspiration. Why? Because if this is the heart, so here you will have the AST. So already the high blood volume is there. Okay, so further increase in venous return will not cause any changes, because already the some blood is entering from the left atrium to the right atrium through the atrial septal defect. Already high volume of blood is there, so increase in the venous return will not cause any changes. Okay, so that is the pathognomic sign, pathognomic for atrial septal defect. So fixed splitting of A2P2 is the pathognomic. Fixed split is nothing but no change with respiration. The fixed split is seen in atrial septal defect. Paradoxical, nothing but reverse splitting. Normally it is A2P2, but now it is becoming as P2A2. So when this has to happen, A2 should move forwards or P2 should move backwards. So let us see how it happens. P2 occurs before A2. Splitting widens on expiration. This is another important point. Splitting widens on expiration. Obviously. Okay, there will be less split in the right ventricle. Splitting will widen expiration. So due to delayed A2, for example, left bundle branch block. So left bundle branch block, delayed conduction to the left ventricle. So delayed emptying of the left ventricle will cause delayed closure of aorta. Aortic stenosis, here also same, the orifices become small, time taken will be more to delay. And hypertension. Okay, so left LBBB, aortic stenosis, hypertension, this will cause delayed A2. So main important cause of this paradoxical or reverse splitting is delayed A2. So aortic stenosis, left bundle branch block, and aortic stenosis and hypertension. Okay, loud P2. So P2 has become, so this you will see in pulmonary hypertension. So here one figure is there. We should discuss this figure. See here. This is normal physiological splitting of S2. Okay, A2, P2. Audible expiratory splitting. So wide physiological splitting, as I have said, A2 should move backwards and P2 should move forwards. For example, P2, when it will move forwards, it will delay in right bundle branch block and pulmonary stenosis. A2 backwards, so a severe mitral regurgitation. In these cases, you will see wide physiological splitting. Reverse splitting, when there is delayed A2, very much delayed A2, so that it is moving forwards of P2. So, and it will increase in expiration. Why? Because in expiration, in inspiration, P2 will move towards A2, because in inspiration the blood flow to the right ventricle will be increased. So P2 will also have some, I will say, will take some time to empty the ventricle. That's why in inspiration P2 will move closer. In paradoxical changes in split in respiration. Paradoxical means it is nothing but it's not only P2 and A2, but it is also paradoxical changes in the splitting with respiration. Okay, so in inspiration P2 will becomes closer, and in expiration P2 will move backwards than A2. Reverse splitting, this you will see when there is delayed closure of A2, for example in aortic stenosis or in left bundle branch block or hypertension. Okay, narrow physiological splitting, increased P2. Okay, increased P2, narrow physiological splitting in pulmonary hypertension. So there is right ventricle needs more pressure to push the blood into the pulmonary artery because of pulmonary hypertension. That's why what will happen? P2 will close early. Because of pulmonary hypertension. P2 will close early because of pulmonary hypertension. So that thing, no. So the split becomes closer. closer. Now why P2 becomes loud? Why P2 becomes loud? So the normal physiological split the gap has become lower. Both are very much closer. So because they are very much close, the sound will be intensified. The sound will be intensified. The sound will be intensified. That's why there is loud P2. Okay, loud P2. Loud P2 when there is pulmonary hypertension. Okay, so that's about splitting of S2. All these are heard as triple Heart sound, remember. So here is I have kept the audio clips also, you can just hear. This is normal split second sound. Just hear. You put the earphones in your ears to hear these sounds good. Okay. Are you able to hear that? Yes, dub is double. Dub is double. Okay, but not much difference. Okay, but this double. Again, one more time. Split test 2. Okay, we'll move towards S3. So S3, the mechanism is, it is due to filling of the ventricle during diastole from atria, passive filling. Remember, if you remember the cardiac cycle. So if this is the left atrium and this is the left ventricle, this is the right atrium and this is the right ventricle. So in diastole, what happens? The ventricle will relax. Ventricle will relax and there is blood in the left atrium. There is opening of the mitral wall, and initially in the diastolic period when the ventricles are relaxing, there is flow of blood from the atria, not only from the I'm just giving example of the left heart of the heart, left side of the heart. So there will be passive flow of the blood into the ventricles. So that causes S3. After that passive flow, there will be contraction of the ventricles. So this causes active flow of the blood through the atrioventricular walls. So this active flow of blood is later. So the passive flow of blood causes the S3 sound. So whenever there is hyper volumic state or hyperdynamic circulation, whenever there is hyperdynamic circulation or volume overload, you will hear this S3 sound. Okay. So low frequency sound from rapid ventricular filling in early diastole, causing deceleration of blood against a stiff or overloaded ventricular wall. So auscultation, best heard because it is a best heard with the bell at the apex. So apex sounds are best heard with bell. Okay, and at the left sternal border, and they will sound as kintukki, 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 kintukki. The key is S3. The key which you hear is S3. Kintukki, kintukki. And one more thing important here is kin will be separate, but this tukki will be together. Kin will be separate. Kin is nothing but S1 and tuk is nothing but S2. Ki is nothing but S3. So you'll hear like this: kin tukki, like this. So here the clip is there, just you hear that clip. Are you able to hear that sound? Okay, one more time. S3. Kin tukki. Okay. So what is the clinical correlation of this? So it is physiologically heard when there is hyperdynamic circulation, for example in children, young adults and pregnancy states. Okay, it is physiological. If it is heard in adults, it is not heard in adults. Okay, not heard in adults. And in adults, if it is heard in adults, it is heard in heart failure, okay, and in constrictive pericarditis. So in heart failure, you will have functional, not organic, functional mitral regurgitation, remember. So there will be volume overload, systolic dysfunction that causes S3 sound. Okay, whenever there is increased volume of blood in the left heart, now you will have this S3 sound. So pathologically, if you heard this sound, you will hear it in what do you call heart failure. Okay, then coming to the fourth heart sound, mechanism is low frequency sound from atrial contraction. This is nothing but, I will explain this. This is due to the rapid gush of blood due to active contraction of the atria, and the atria are contracting, they are pushing the blood towards a stiff ventricle due to hypertrophy of the ventricle. So contraction of atria pushing the blood towards a stiff ventricle causes the S4 sound. Okay, anything which causes ventricular hypertrophy will have this S4 sound. For example, so non-compliant ventricle in late diastole. So this S3 and S4, remember, these are heard in diastole. So if this is S1, this is S2, and this is systole, and this is diastole. So S3 is in early diastolic period and S4 is in late diastolic period. Okay, S3 is in early diastolic period, S4 is in late diastolic period. You will heard this as thinnessy. And one more point here is, this 10 is nothing but S4, ness is nothing but S1, C is nothing but S2. Okay, and one more here is, this 10 and ness will be heard with in combination, and C will be heard somewhat separate. Tennessee, like this will be Tennessee. So just hear this clip. One more time. That's S4. Okay, what is the clinical correlation? It is always pathological. Remember, S4 is always pathological, whereas S3 can be physiological, but S4 is always pathological. So it indicates ventricular hypertrophy or impaired relaxation. Anything which causes ventricular hypertrophy will have S4 sound. Hypertension, aortic stenosis, hypertrophic cardiomyopathy, and ischemic heart disease. So these all cause left ventricular hypertrophy. Now coming to the last part, additional sound like clicks, snaps, and rubs. Remember, click is a systolic sound, snap is a diastolic sound, rub is also a systolic sound. Okay, so click is ejection click is heard during the systolic, is heard in early in systole, heard when with congenital bicuspid aortic valve or pulmonary stenosis. Remember, pulmonary stenosis, pulmonary valvular stenosis, you will have this ejection click. So that opening, that opening will cause bicuspid aortic valve and pulmonary stenosis. Something problem with this two will have systolic click. So clicks are heard due to problem in the aortic and pulmonary valve, and these are systolic. Just I am playing this audio clip, just hear this one. It is loud. One more time. That is ejection click. Okay, mid systolic click is a signature of mitral valve prolapse. Nothing but is a pathognomonic of mitral valve prolapse, MVP. Why this happened? This is because of tensing of the caudate tendon. What happens? So this is the left ventricle and this is the left ventricle, left atrial, left ventricle. If this is the mitral wall, this will go very much backwards in the left atria. So normally these are connected with chordate tendino. So because they are moving very much backwards, because the mitral wall cusps are very much floppy, so they will move very much backwards during the systole. During the systole, they will move very much backwards. So these strings, nothing but chordate tendinae, will be tensed. They'll become stout, and they'll become tight. The tightness, the tenseness of chordate tendinae will cause the mid-systolic click. That is signature of the mitral valve prolapse. Okay. Triple alert sound, again, all these are heard as triple alert. You need to differentiate. Okay. Opening snap, again, opening snap is heard in mitral valve problem or tricuspid valve problem, mitral valve problem or tricuspid valve problem. So it is the early diastolic sound, it is high pitched, and it is pathognomonic for mitral valve prolapse. As we have learned here, mid systolic click is the pathognomonic feature of MVP. The opening snap is the pathognomonic feature of mitral stenosis. Okay. Interval between A2 and OS, nothing but the A2 part of the S2, and the OS shorten with worsening stenosis. As the stenosis grows up, the OS will become closer to the S2. Opening snap. So just hear this opening snap heart sound. One more time. That is nothing but opening snap. Now pericardial friction rub. So it is a superficial scratchy, squeaky sound with 1 to 3 components per cycle. Now this is pathognomonic for pericarditis, and this is louder or inspiration with patient leaning forward on firm pressure with the diaphragm. You should hear with this with the diaphragm, pericardial friction rub. It is a pathognomonic feature of pericarditis. So here the one flow chart we need to discuss here. See here. So this is S1, this is S2, which has two components, A2 and P2. Opening snap is the pathognomonic feature of metastenosis, and it is present very near to the in early diastole will be there. Okay, mitral stenosis. And this is S2. This is the mid systolic click, which will you hear in the MVP, mitral valve prolapse. And this is the early ejection click or opening of the sound of the aortic, bicuspid aortic valve or pulmonary valve stenosis. Okay, that's click. Clicks are systolic. Okay, and opening snap is diastolic, early diastolic. You need to differentiate opening snap from S3 because S3 is also diastolic and it is early. Here you see here, this is the S1. Oh, sorry. This is S1. This is A2, P2. This is S3. Okay, and this is S4. This is a late diastolic is S4. Early diastolic is S3. Now this is the summary of whole thing which we have learned. Just will revise in minutes. Okay. S1, onset of systole, usually single. It is due to closure of mitral and tricuspid valves. Clinical correlation, loud or soft. Okay, this is loud when the circulation is hyperdynamic. S1 is loud when the circulation is hyperdynamic circulation, like anemia, pregnancy, thyrotoxicosis. So relatively there is large amount of blood which has to gush through the normal valve, and S1 is loud in mitral stenosis. Now here blood amount of blood is normal, but the orifice has become small. So relatively again there is mismatch in the flow of blood. Okay, now this will become soft in cases of heart failure and in mitral regurgitation. S1 is loud in mitral stenosis and hyperdynamic circulation, and also in tachycardia. We have learned, no, tachycardia, also in tachycardia and short PR interval. And S1 is soft in heart failure. Okay, in heart failure, mitral regurgitation, obesity, pericarditis. Okay, long PR interval also. Okay, important to remember is heart failure and mitral regurgitation. Heart failure and mitral regurgitation is soft S1, and loud S1 is in mitral stenosis and hyperdynamic circulation. Coming to the second heart sound, at the end of systole, this has splitting. So wide splitting, fixed splitting, and reverse splitting, and loud P2. Loud P2 in pulmonary component of the S2 will be loud in pulmonary hypertension. So split in on inspiration, single on expiration. Due to closure of aortic and pulmonary, it has A2 first, P2 second. Fixed wide splitting is a pathognomonic of ASD. Wide splitting but variable. This is due to delayed right bundle branch block. Okay, delayed right heart emptying, right bundle branch block, you will have wide splitting. The P2 has to move forwards. Okay, delayed filling, no. So pulmonary stenosis also you will have wide splitting, and right bundle branch block will have wide splitting. Early closure of A2 will also have wide splitting. Remember, just when there is right bundle branch block, there is wide splitting. Reverse splitting is you see in left bundle branch block. Also when the A2 when it moves forwards of the P2, so very much delayed closure of aortic valve will have paradoxical or reverse splitting, that you can see in aortic stenosis, hypertension, aortic stenosis. Okay, and left bundle branch block. Now S3, early in diastole, low pitch. Remember this one, when there is S1, S2, S3, this is known as S3 gallop. S3 gallop is, this is something like a horse which is running, and the sound of its steps, the sound of the steps of a horse which is running, that is known as gallop. Okay, so when S1, S2, S3 are there, that is known as S3 gallop. S4 gallop is nothing but S1, S2 plus S4. So that is known as S4 gallop, S3 gallop and S4 gallop. So third heart sound, from ventricular wall due to abrupt cessation of rapid filling. Physiologically, it is heard in young people in pregnancy. Pathologically, it is heard in severe mitral regurgitation and heart failure patients. Fourth heart sound, late diastolic sound just before S1, low pitch, against a stiff ventricle. When the blood is gushing, then you will heard S4, and it is always pathological. Okay, stiff, any cause of left ventricular hypertrophy will have this. So it is absent in atrial fibrillation. It is a feature of left ventricular, severe left ventricular hypertrophy, So clicks are systolic. It can be early or mid systolic is nothing but due to mitral valve prolapse. Okay, brief high intensity sound, it is in aortic stenosis or pulmonary stenosis. So clicks are, because they are in systole, any problem with aortic or pulmonary valve will have clicks, systolic clicks. Floppy mitral is the MVP, mitral valve prolapse, tensing of the chordae tendineae. Okay, clicks are lost when the stenotic wall gets thickened or calcified. I said, so stenosis is nothing but thickening of wall. Stenosis is decrease in the diameter of the orifice. The wall may not be thickened, but the orifice will become less. So later that cusp can become calcified or thickened. Okay, So that's about clicks. Opening snap is a pathognomic feature of mitral stenosis. It is heard early in diastole, so you should differentiate it from S3. Opening of stenosed leaflets of mitral wall, that is the mechanism. And opening snap will move closer to S2 as mitral stenosis becomes more severe, may be absent in calcific mitral stenosis. So this is about heart sounds, triple heart sound. So in the next video we'll learn about heart murmurs. Thank you for your listening.